Assalamu alaikum. I would just like to thank Dr. Mullah and his colleague for being so nearly on time, only 15 minutes delay. So I promise you we will finish our session, the last session this morning, in 30 minutes. So it means 1:45 will go on to close on the second, inshallah. I would like to welcome you to welcome our guest speaker, Dr. Lionel Rostaing. I was expecting to speak German, but he spoke only English and French. He was for some time in Heidelberg. That was my hope. He is a professor and consultant in clinical transplantation at Toulouse University. And he obtained his nephrology in 1988 and immunology specialty 1 year after in Marseille. During this period, he obtained his scholarship in Heidelberg as well as Brussels. His interest mainly in research in the field of infection with hepatitis C in renal transplant and hemodialysis patient, as well as the liver transplant patient. And he has interest in other viral infection too. He published more than 40 articles and 200 papers. Please welcome him with me for the interesting subject he's going to speak about, the use of m-TOR inhibitor after de novo transplantation, kidney transplantation, and maintenance kidney transplantation. He will give us, I think, 3 studies review on AVR. Please.
Thank you, Dr. Osman, for this kind introduction. Good morning. First of all, I would like to thank the GCC organizing committee for inviting me, as well as Novartis KSA for giving me the opportunity to share with you some thoughts regarding the use of everolimus, which paves the way in organ transplantation, and particularly in kidney transplantation. So what is the rationale for using m-TOR inhibitors in kidney transplantation? Well, as you know, that both everolimus as well as sirolimus belong to the m-TOR inhibitors family, and they have anti-proliferative properties, and they act either synergistic with cyclosporin A or they act additively with tacrolimus. And therefore, the use of everolimus, for example, permits low cyclosporin A exposure in kidney transplant recipients. So if you compare everolimus and sirolimus, they belong to the same family, obviously, but what are the differences? Well, first of all, their half-life. Their half-life is far much different. 1 day for everolimus, about 5 days for sirolimus. Therefore, when using everolimus as compared to sirolimus, you may reach the target sooner. A loading dose is not necessary with everolimus. When dose modification is to be done, the new target is achieved quicker. And finally, when side effects do occur, the dose reduction might result in sooner improvement. And finally, the side effects profile are different with the 2 drugs. For example, sirolimus results in more wound healing problems, more lymphocyte, more DGF, more interstitial pneumopathy. So, just to recall you the mechanisms of action of m-TOR inhibitors. So when IL-2 is binding to its receptor, it activates a downstream cascade, which results in m-TOR activation, and sirolimus as well as everolimus bind to FK binding protein 12, and that complex will inhibit m-TOR protein. Thereby, when m-TOR protein is inhibited by this complex, this results in the inhibition of downstream events, which will result in the inhibition of angiogenesis via the EGF pathway, the inhibition of cell proliferation, interference with apoptosis, and this will result in the interference with the immune system as well as the prevention of tumor growth. So for which reason are we using m-TOR inhibitors in kidney transplant patients? First of all, to avoid the calcineurin inhibitor-associated nephrotoxicity, which is well documented, but also to improve the long-term allograft kidney function. Why? Because, as you know, the serum creatinine at 6 and 12 months post-transplantation are surrogate markers for long-term allograft survival, and therefore, if we improve early kidney allograft function by using m-TOR inhibitors, this might translate in the long run by better allograft survival, and eventually to prevent or to reduce the burden of de novo post-transplant malignancies. So those are the main reasons for using m-TOR inhibitors. But can m-TOR inhibitors replace CNIs in kidney transplant patients? So we have two strategies to use m-TOR inhibitors. The first one was an absolute CNI avoidance, and this was developed with sirolimus, but this strategy is no longer in use for many reasons. So the second strategy is to use a very low dose of CNIs plus m-TOR inhibitors, sirolimus or everolimus, and this strategy was mainly developed with everolimus. So just to recall you a recent meta-analysis by Webster that examined the rate of CMV infection post-transplant with regards to the immunosuppression that was given to a patient, either m-TOR inhibitors or antimetabolite in addition to CNIs. And what they showed is that those patients who are on m-TOR inhibitors had a significant decreased risk of 51% of CMV infection as compared to those who are on antimetabolite. So in addition to their immune properties, m-TOR inhibitors also prevent some viral infections. So we're going to examine 3 studies that use everolimus either in de novo kidney transplant patients or in maintenance kidney transplant patients. The first study, published very recently by Elio Tedesco in AGT, is a 12-month study that examined 2 dosage of everolimus in combination with cyclosporine A versus cyclosporine A plus NPA. And this study permits the registration of everolimus by the FDA some months ago. So the background for using everolimus plus low-dose cyclosporine A was that about 10 years ago, the full exposure of cyclosporine A plus everolimus resulted in poorer allograft function. And therefore, when everolimus was used with reduced cyclosporine A in some studies, the renal function was better. But this was examined in a proper way in a double-blind prospective study which included a lot of patients. So the study design was as follows. At transplantation, the patients received basiliximab induction therapy with or without steroids. And there were 3 arms, a standard arm with standard cyclosporine A plus NPA, and 2 study arms with reduced exposure to cyclosporine A. You see the trough level for cyclosporine A were far much lower as compared to the standard cyclosporine exposure, with either everolimus 1.5 mg per day, aiming at troughs between 3 to 8, or everolimus 3 mg a day, aiming at troughs between 6 to 12. So the primary objective was a non-inferiority of either everolimus regime versus NPA for the composite efficacy failure. And the main safety objective was to demonstrate the non-inferiority with regards to calculated GFR. So the inclusion criteria was any patient aged between 18 to 70, a recipient of a primary kidney transplant. So there were more than 270 patients in each of the 3 arms. Almost all the patients completed the study. With regards to the everolimus arms, the 2 arms, the patients were within the pre-specified targets, and this was true for the 1.5 mg per day, as well as for the 3 mg everolimus per day. So the protocol was well respected. With regards to cyclosporine A exposure, the exposure within the control arm was standard, that is to say with NPA, whereas the exposure with everolimus was significantly decreased, and this was decreased by almost 70%, because if you compare the trough levels at 1 year, you compare 136 to less than 50. So that was a huge decrease of exposure to cyclosporine A. So for the results, with regards to the primary composite endpoint, this was similar across the 3 arms. So the non-inferiority efficacy was achieved. With regards to the treated BPARs, the incidence was very similar across the 3 arms, between 13 to 17%. Most of the acute rejection were of grade 1A or 1B, and with regards to the grade 2As, they were mainly in the NPA arm as compared to the everolimus arm. So same grade except for 2A that were more frequent with NPA. With regards to the secondary endpoint, which was the calculated GFR, the CGFR was significantly better from the beginning till the end of the study in the everolimus 1.5 mg per day as compared to everolimus 3 mg or NPA. So that is to say, with low cyclosporine A exposure plus low everolimus, you achieve the best GFR in that study. A concern, what about proteinuria? If you examine proteinuria over creatinine ratio, this was similar across the 3 arms. With regards to cyclosporine A related side effects such as tremors, asceticism, goblet they were mainly observed in combination with NPA, but very less frequently when cyclosporine A was combined with everolimus. What about viral infection? As I mentioned earlier, a meta-analysis has shown that m-TOR inhibitors might prevent from CMV infection. In this prospective study, where BK virus and CMV virus were prospectively monitored, the authors found a significant decrease in BK virus replication as well as CMV replication in the everolimus arms as compared to the NPA arms. So it also demonstrates that everolimus plus low cyclosporine A is able to decrease BK virus and CMV virus replications. What about wound healing problems? What about limb seal? The percentage of these events were quite similar across the 3 arms, even though they were slightly numerically higher for everolimus 3 mg per day. What about de novo neoplasms? They were numerically lower in the everolimus arms as compared to the NPA arm, but the difference was not statistically significant. So the conclusion of this first study is that both everolimus 1.5 and everolimus 3 mg per day in combination with very reduced exposure to cyclosporine A versus NPA plus full exposure to cyclosporine A results in a similar composite efficacy and renal function at 1 year. This study also showed that the best GFR was achieved when combining everolimus 1.5 plus cyclosporine A. And finally, this kind of strategy allows a dose reduction of cyclosporine A of approximately 60%. Okay, so this was the early use of everolimus from the transplant day onwards. What about early conversion from CNI to everolimus? So the most prominent study published recently is the ZUS data. So the ZUS trial is the everolimus-based calcineurin inhibitor-free regimen in recipients of de novo kidney transplant patients. This is an open-label study randomized control trial. So this is a German trial. At the very beginning, all the patients received basiliximab, steroids, cyclosporine A full dose plus NPA. And 4 to 5 months post-transplant, they were randomized either to be maintained within the same regime or to be converted progressively from cyclosporine A to everolimus, aiming at troughs for everolimus between 6 to 10. So all the patients were randomized except if their serum creatinine was greater than 3, or if they had proteinuria over 1 gram per day, or if they have had acute rejection of grade band 2, or if they were on dialysis, obviously. And so this was a 2-year study. And so after month 5, the patients had either everolimus plus MPA or cyclosporine A plus MPA. And the primary endpoint was the calculated GFR at 2 years. So in brown, you see the patients were maintained on cyclosporine A plus MPA. In blue, you see the patients were converted from cyclosporine A to Certicat. And you see that at 2 years, there's a huge and significant increase in GFR of more than 7.6 milliliter per minute. And this was achieved as soon as 2 months after randomization. And this was sustained. You may argue, what about acute rejection? If you look at acute rejection rates, both at 1 year and 2 years in that study, they were very similar across the 2 arms. So no concern about that. According to the grades of acute rejection, most of them were borderline or band 1. So no concern regarding BPARs. What about side effects? Well, there were more thrombopenia, more diarrhea, and more mouth ulcerations in those patients who were converted to everolimus as compared to those who were maintained on cyclosporine A. But these side effects were easily manageable. What about malignancies at 2 years? Numerically less malignancies in everolimus-treated patients, but the difference was not significant. And numerically slightly more proteinuria, but it remained in reasonable ranges. So the conclusion of this very important study is that withdrawal of cyclosporine A 4 to 5 months post-transplant under the umbrella of everolimus brings a similar efficacy, a similar safety, but translated in a significant better allograft survival. So I think it's a milestone study in this strategy. And finally, the last study I want to share the results with you is the Ascertain Study, whereby the maintenance kidney transplant patients were converted from CNI to everolimus. This recalls the CONVERT study, which had quite the same design some time ago with sirolimus. So the design of Ascertain was as follows. This is a 2 years open-label multicenter randomized controlled study that included almost 400 patients. So all the patients had to be at least 6 months post-transplant. They had to be on maintenance immunosuppression based on CNI, with or without NPA, with or without ASA, with or without steroids. And so they are randomized into 3 arms. Arm A is maintained on CNI. Arm B is wean off of CNI under the umbrella of full exposure of everolimus, aiming at troughs between 8 to 12. Whereas in group C, CNI are reduced to the maximum level that can be achieved, plus everolimus aiming at troughs between 3 to 8, so in between. So the patients included had to be transplanted for at least 6 months, recipients of a primary or secondary kidney allograft, with stable levels of tacrolimus or cyclosporine A, and their GFR, their estimated GFR had to be between 30 to 70. So there were roughly 130 to 144 patients in each arm. The rate of completers was quite similar across the 3 arms, except in arm B. And you have to see that almost all the patients were between 5 to 6 years post-transplant. And this time lag between transplantation to implementation of this strategy might have explained the results that I will share with you in the next slides. So if we look at the patients who were converted to everolimus in group B, the trough was aimed at between 6 to 12, or in group C, aimed between 3 to 8. The patients were within the target, the pre-specified target. So the protocol was very well respected by the physicians. So what about arm C, where CNI were reduced? In arm C, under the umbrella of everolimus, tacrolimus was reduced on average by 60%, whereas those patients who were on cyclosporine A, this was reduced on average by 77%. So in arm B, the use of everolimus allowed a huge reduction of cyclosporine A. So what about the results? So the result was the measured GFR at 2 years post-randomization, and it was assumed that there would be a 5 milliliter difference in favor of those who were converted to everolimus. And this primary endpoint was not met. As you see, for those patients who were maintained in the CNI arm, those in whom CNI were totally discontinued, and those in whom CNI were reduced under the umbrella of everolimus, the GFR did not significantly change at all. And this might be due to the fact that we were long after transplantation, and these results recall those from the CONVERT trial. However, we performed a post-hoc analysis in order to look at the independent predictive factors which were associated with a measured GFR decline at 2 years post-randomization. So this is a post-hoc analysis. But in that study, we found that the donor age, the time since kidney transplantation, and finally, the mean DFG at inclusion were significantly associated with the decline of GFR 2 years later. That is to say, those patients who had the best measured GFR at inclusion were those in whom there was the less decline of GFR at 2 years. So in this study, the rate of BPARs was very low across the 3 arms, as well as the graft loss or death. So the conclusion of that study is that the introduction of everolimus long after transplantation allows for a substantial reduction or discontinuation of CNIs in maintenance kidney transplant recipient with no significant difference in efficacy or renal function. However, there were some adverse events in the everolimus arms. We also said that selected subpopulation with good renal function at inclusion might benefit from conversion from CNIs to everolimus therapy. And so the last part of my talk, 1 slide or 2, is how to convert a patient from CNI-based immunosuppression to m-TOR inhibitor-based immunosuppression after kidney transplantation. So if we focus on everolimus, because of the half-life of everolimus, there is no need for loading dose, so no loading dose. However, you may make an overlap between everolimus and CNIs for at least 5 days just to reach the target level for everolimus. The starting dose of everolimus could be or should be 1.5 milligram twice a day, aiming at troughs between 4 to 8 nanogram per milliliter. And the first trough level is performed at around day 6 post-conversion. And finally, if a patient is having concurrently MPA, MMF or myfortic therapy, especially if you receive MPA plus cyclosporine A, if you switch off from cyclosporine A to everolimus, you have to decrease MPA by at least 50% in order to limit the potential side effects of the overexposure of MPA in the absence of CNIs. So just to conclude, in maintenance kidney transplant recipients, the early conversion from CNIs to everolimus has a huge beneficial effect upon renal aerograph function, and this is the JUST study, and this study changed my way of using immunosuppressant, because now we are converting a lot of patients from CNIs to m-TOR inhibitors after month 4 to 6 post-transplant. The late conversion from CNI to everolimus is feasible, but has very marginal benefit regarding renal function, except in those patients who have the highest GFR at conversion. And this might prevent degradation of GFR afterwards. And this may have a benefit regarding the occurrence of de novo post-transplant malignancies, as this was shown with the sirolimus trials, the CONVERT trial, for example. This was not the case yet for the certican trials, but maybe the follow-up is not long enough, or the number of patients was not enough. So I thank you for your attention, and I'm sorry for the time it took to give the presentation, but we are late. Thank you.
Very elegant summary and presentation, very convincing data. And thank you very much for respecting the time of the people. We'll have enough time, I think, for a few short comments and long questions, if you understand me, please. So, question, please.
Thank you very much, Dr. Rostaing, for this nice presentation. But in fact, the data you presented is completely contradicting the Orion trial, which was using the second mate of m-TOR family, which is sirolimus. The arm of CNI without CNI was aborted after 6 months because unexpectedly higher rates of rejection. And the other arms show superiority of CNI continuation rather than holding the CNI as early as 3 months. What I can understand from the presentation that maybe everolimus is more senior, more superior than sirolimus, but no data is supporting this.
So thank you for this comment. As you know, the Orion trial has been published by Stuart Fleckner as the first author very recently in AGT. And as you mentioned, the Orion trial was amended, and the sirolimus arm was suspended very early. Why? Because in that study, the patients were given induction therapy without CNI, but only in this arm you mentioned, sirolimus plus NPA. And this was a failure of that strategy. Whereas in all the studies I presented to you, everolimus was given from the beginning with CNI, and CNI were weaned off after 4 to 5 months. And I think you benefit from the synergistic effect of cyclosporin A plus everolimus with regards to the potent immunosuppression. So therefore, you avoid acute rejection. And after a period of 4 to 5 months, you can safely discontinue CNIs under the umbrella of everolimus plus NPA, because you are away from the period of at risk for acute rejection. And so therefore, all the strategies that were implemented with sirolimus, so no CNI, I mean, not the very first one, but afterwards, no CNI, sirolimus plus NPA plus induction, failed. Failed why? Because there was no CNI on board from the beginning. And this is the big difference, I think.
Thank you for the answer. Do we have other comments, please? The lady side, as Ramallah used to say. Any comment? Go ahead, Ansarullah.
It's for me a little, not that reassuring. Having GFR the same in the group who is still on calcineurin inhibitor, cyclosporin, and the group who were withdrawn to everolimus. We know that the hemodynamic effect would expect that higher GFR just for the mere removal of this effect. Now, having the same GFR is a bit worrying, given also that in CONVERT study, at 12 months, 6 months, that excellent GFR difference was almost lost by 24 months, comparison in the GFR between the two groups. These points might suggest a hidden, ongoing rejection process that probably affecting the underlying renal function throughout the time. What do you think about it?
Well, I think that too late is too late. I mean, I think there is no point to attempt conversion from CNIs to m-TOR inhibitors too late after transplantation. Why? Because the kidney damage is already there. I think, let's say, fibrosis, and if you convert from CNIs to m-TOR inhibitors, the CONVERT trial, the Ascertain trial, you have no benefit at all, even the hemodynamic benefit. So there is no point in those patients to convert them except if they have a de novo cancer. And so the point is to convert earlier on. This is the JUST study, for example. This is the SPERVENEFRON study. This is the CONCEPT study. Studies in which conversion from CNIs to m-TOR inhibitors, sirolimus or certican, was attempted between month 3 to 6. So that is to say, before the CNI-related nephrotoxicity lesions have been fixed. And so if you attend this conversion at that time, I think you will have the benefit. And this was the case in the concept trial, spironolactone, and ZUS trial.
That's all right, go ahead.
Was having now in the study you presented the same GFR in the two groups. Now the same GFR in the group with cyclosporine withdrawn. I would have expected GFR to come naturally a little higher.
Yeah.
Having it the same value as those on cyclosporine is worrying. I mentioned the other study that with time the gain in GFR was lost over time, over 24 hours. In the group on m-TOR inhibitor, over 24 months, they lost that initial GFR difference. And that was raising the question that I would naturally expect GFR higher in the group with cyclosporine withdrawn.
I want just to comment on the fact that if you address the belatacept trials, benefit studies, which is a bit different for sure, but the difference in GFR you have in those who were on cyclosporine A and those who were on belatacept does exist from the beginning and is maintained throughout year 3. Why? Probably or possibly because you avoid CNIs from the beginning in that case for belatacept. And therefore, if we come back to m-TOR inhibitors, we have to use them as early as possible without CNIs at some point if we want to preserve the GFR. But if you want to convert too late, it's too late, and you will have no benefit at all, I think. And Ascertain convert showed that too late is too late.
Thank you very much, Professor Rostaing. In the name of the audience, I would like to thank you for the very elegant and convincing talk, despite the comment of some people. We will finish for prayer and lunch, and the schedule will go again 15 minutes later, it means 1:45. Thank you very much, and bon appetit.
Thank you.
It was very convincing.
This microphone on, my friend? Rahim. Assalamu alaikum. Good afternoon. It seems that our friends, they enjoy their lunch more than should be. We'll come back again to the session 7. The first speaker is Dr. Hassan Al-Sulh. He completed his medical degree in the American University of Beirut, his pediatric residency training and fellowship in pediatric hematology and oncology in Canada, and has been a consultant pediatric hematologist-oncologist since 1988. He established the pediatric stem cell transplantation program at King Faisal Specialist Hospital in 1992. His presentation today will be use of stem cells in solid organ transplantation.